right, well, thank you all for being here today. What I'm going to talk about today is how much Osseodensification has changed the way I practice implant dentistry. We've all been saying the same thing, it's a paradigm shift, but why is it a paradigm shift? Being in academia, you're very often exposed to new technologies and new things. Every day there's someone knocking on your door with this new thing. And some of them are okay, others are not, or most of them are not. So when I was first introduced to this, obviously I was very curious. But more than that, it made me think. And I do like things that make me think. More than that, it also made me rethink a lot of things that I had been doing since I was trained in periodontics and obviously in implant dentistry as well. So, having said that, we know what implant dentistry has done to dentistry. It has completely changed the way we practice dentistry. Implant dentistry was not developed by surgeons, as we all know. It was developed by those who need to restore patients, restoring dentists or prosthodontists. They were the ones that were always challenging with the stability, the fixation of the prosthesis that they were delivering to patients. And when no teeth were left, they were left with very few options. So a lot of creative work was done in the past, and I admire all of that because, as I'm going to say a little bit later, it's very easy to criticize other people's work. It's very difficult for you to just be there, have an idea, and to make it happen. And a lot of what we are talking about today is a result of all of that. So many ideas have come up until we develop something that is a little bit more user-friendly and gain acceptance and used worldwide. Implant dentistry, as I said, really changed the way we practice dentistry. And it continues to evolve and evolve on a daily basis. Nowadays, we're no longer worried about fixation only because we know we can achieve that. We're worried about other things. We're worried about aesthetics, predictability, how reproducible things are. And more we get to a point where we will be comfortable with what we're providing to our patients on a daily basis. It's impossible to talk about implant dentistry without talking about this person. Unfortunately, last week, I lost one of my most important mentors. More than that, I lost a dear friend and someone that I really, really admire. And yes, it's emotional when you lose someone that you admire so much. But one of the things that this loss did to me was I went back and started to look back at everything that I had learned from him. This man was a brilliant mind. That's my conclusion. That's how I sum it all. Because he was so ahead of his time that it may take another 10 years for us to finally start to understand what was going through his mind when he was talking and working. This man was not a genius, because if you're a genius, you're born that way, you don't have to work. He was a hard worker, always curious to find answers for things. He happened to be a dentist, and he found challenges in dentistry, and he looked for solutions. When implant dentistry started, there were a lot of big unknowns. And he found answers for all of this, not in dentistry. That is probably my deepest respect for him, is just how brave he was. He went to the medical field to learn about bone grafting, because bone grafting wasn't something that was done normally in dentistry. He went to the engineers to learn more about bioengineering and design and things that we don't know. And that's why we have all this work. So I went back and started looking at this book here. This book was published the year I started my residency at University of Michigan. published in 1999. I was very lucky to have him as my mentor at University of Michigan in implant dentistry. I didn't even know who he was. I didn't know he was famous. He just walked in the lecture room one day with 16 slide carousels, and he just like delivered all of that in 1 hour. Like I was almost like completely brainwashed by the end of the lecture. He's just such a powerful speaker. But by looking at this book, that to me still is my Bible of implant dentistry, I know that there have been like new editions, and they have updated a couple of things, but the key concepts there have not been updated. And when I was reading this during this last week, I started to finally understand a lot of things that he had said before and I couldn't understand before. So let's look at these 2 chapters. And if you have this book in your office, and by the way, I don't know if you know this, but this book is the best sold book in dentistry ever. Ever. If you look at these 2 chapters, 8 and 25, look at the title of the chapters. Bone density as a key determinant for clinical success. Density of bone, effect on surgical approach, and healing. This was almost 20 years ago when it was published. What did Misch say in 1999? His concern was that there was a high failure rate in poor bone quality. There was also the highest failure rate in posterior maxilla, as we know that where we have poor bone quality. Density of bone evolves as a result of mechanical deformation from microstrain, so bone needs to be loaded in order to develop density. And density decreases significantly where patients are edentulous. Duh, that's exactly where we have to put our implants. We all know the difference between drilling an implant osteotomy on a site that has been edentulous for a long time or doing that on a fresh extraction site. Bone is a lot different. That bone hasn't been stimulated in a long time. So there is a certain region here where this microstrain can develop bone or can help develop bone density. But obviously, if you pass a certain limit, then you may have pathologic overload of bone that can cause problems like bone loss and undesirable remodeling. So this is all that Misch said in 1999. He also developed this bone density classification scale. We almost forgot that there was a D5 in there. We all know what D1 to D4 is. He describes D1 as dense cortical bone, D2 would be the thick, dense, with porous cortical bone and some well-defined trabeculation. D3, we don't have the same trabeculation, and D4 is a very weak bone. With this classification, he also pointed out where we found these types of bone in the mouth. If you look at chapter 25, here's where he looks at how this affects healing of an implant. We may think that D1, according to him, was the best type of bone that a patient should have. It's not. And it's obviously true why it's not, because if the bone is so dense and it's so mineral, it can't have enough organic component that is needed for the bone to heal. There's less blood supply there. He points out that D2 is actually the best bone. So here's the first lesson that he taught us in 1999 that applies to everything that we're talking about here. Everybody that has been exposed to osseodensification has made this mistake, and I've made a lot of mistakes with osseodensification, and that's how I learn, and that's what I'm going to share with all of you. I always thought that my goal is to turn a D4 bone into D2 or D1 bone. The truth is that D2 is desirable, yes, but D1 is not desirable. And that was my mistake. There's a limit to how much you should densify bone. Because if you densify more than you should, and you turn that into a D1 bone, you may have issues with healing. So yes, you have this optimal primary stability and everything else, but you may not have the best healing that an implant should have. So something to keep in mind. It also shows us something very obvious here, that densification is a tool. It's something that you should use when needed. It shouldn't be used all the time. When I started using it, I was drilling everything counterclockwise, and I wanted to create D1 bone everywhere. And I ran into a lot of issues because of that. And I think that that's also something important to remember. It's a tool. You have that on your handpiece with you all the time. You assess, you identify that the bone is softer than it should be, then you densify. But it also will tell you when you have densified enough, or when you have started to cross the line and densify more than you should have. Based on the limitations that existed back in 1999, Dr. Mish traveled to UAB, School of Engineering, the best schools of engineering in the world, and he learned from them about design and features that we have never learned before. As a result of that, he developed his implant system. You know, he was one of the founders of BioHorizons. And this was the very first attempt to address bone density in implant dentistry. Back then, there was one implant system that we all knew, but that implant was not very successful in poor bone quality. So what did he do? He developed the design of the implant and developed one type of implant for each type of bone. So obviously, you would have to have a large inventory in your practice, because since you assess bone density at the time of placement or at the time of osteotomy preparation, you really don't know which kind of implant you're going to use. So, oops, I planned for a D1 and I needed a D3 right now, so if I don't have it, what am I going to do? But it also shows that some designs here were not optimal for certain types of bone density. Back then, for D4 bone or posterior maxilla, the only solution was to power boost the implant, not only with design, but also with surface coating, which was hydroxyapatite. We all know how successful it was in terms of osseointegration. There's true bonding between the implant and the osseous structure. However, we also learned that that wasn't very stable over time, and that's why these implants are no longer used. But this was a very early attempt. He also showed that bone had to be prepped differently according to areas in the mouth and bone density. So what does this graph here show? You see D1 is conventional, what all implant systems show, same type of design. D2, some modification, you may not need to countersink it as much, you may not use the bone tap. D3, you start to consider like under-prepping the osteotomy more. What do I mean about under-preparation? Making the hole smaller so that the implant can go in tighter. But D4, look at his recommendation here. Sorry, I flipped the wrong one here. So if you look at D4, there's a substantial difference here. You don't see any drills here. What do you see here? Osteotomes. I learned that from him. You're dealing with D4 bone, posterior maxilla. You start your osteotomy, but you finish it up with an osteotome. That's how you create higher bone density. Basically, you are compressing bone, you're breaking it internally so that the implant can find more bone when it goes in and has a tighter space. That was a lot of fun. I used to walk around with a mallet in my pocket because I was just like hitting that osteotome all day long. Maybe I had fun, but I know that my patients didn't, right? It was very traumatic, and this could also cause some problems during healing. It may delay healing depending on how traumatic this was. But this was an early attempt to increase bone density. Mish described a method to densify bone. What we are talking about today, or have been talking about for the last 3 years, is what I call modern osseodensification. Because that approach maybe was successful back then, maybe not as successful as it is right now, but was a little bit traumatic to our patients. So we have to thank another one of my mentors, because Dr. Quaice was volunteering in our clinic on a monthly basis. His practice is in Jackson, Michigan, just about 30, 40 miles away from Ann Arbor, where I went to school. And back then, Dr. Quaice was already talking about this. That's just one idea that he had in his mind, and he just wanted to take it further. He worked hard, he built his practice, he saved enough so that he could live his dream. He reached a point of his life that he could have just settled, come here and play golf instead of, running a meeting like this. No, he decided to go after his dream. And he was very persistent, and that's why one day, back in 2014, he actually, beginning of 2014, he shot me an email, and he told me, like, well, I need to talk to you at an AAP meeting. Would it be okay for us to sit down and have a chat? It's like, sure. Then he came to me, and he told me about his ideas and what he was doing. It's like, oh, are you interested in doing anything with it? It's like, yeah, of course. I want to see it. I want to try it out. I want to see how it works. A couple of weeks later, I got this in the mail. And I'm saving this a lot for the Versah Museum, okay? This is the very first prototype that he sent me. That's how things look. It didn't look very nice, right? I mean, like, the burrs were pretty similar, but, the kit, the burr block wasn't as nice. The collars weren't as nice. But I got this to work, not immediately, obviously, because I got this thing in the mail. I put it in my desk. I left it there for a couple of months. Until one day, I'm about to place an implant, and I realized that my assistant didn't sterilize the kit. I didn't have any drills to use. So I went ahead. It's like, OK, I'm going to use that. First time I started drilling an osteotomy, I felt like, wow, this feels different. I drilled my osteotomy. It was so easy, cut bone like butter, and I did a great job of it. And I love the fact that it was universal. Because how many times do we run into that? You have to have a second or third implant case, and the kit may not be sterile or whatever, maybe missing a driver. I could use this for all implant systems that I place. And I do place about 10 different implant systems on a regular basis. So this versatility, I immediately loved, because it allowed me to do a lot and to treat a lot of patients, with the same drill system. And I did a couple of cases, and I called him, like, oh, Salah, this is really cool. I mean, like, it works really well. And then he asked me, how did you drill? What drill speed did you use? It's like, I use like 900 like I normally do. Did you drill in forward or in reverse? So like, no, I forward, obviously, right? So like, oh, you don't remember what we talked about? This cuts in reverse. It's like, I had completely forgotten. And I said, like, really? But we cut in reverse? And then I tried, and it worked. And when it worked in reverse, it's like, that's really cool. And then I was trying to place the implant, and it could barely place it because the bone was so dense. That's when I had a couple problems, because I was playing with densification, but I didn't fully understand it yet. So did I have my failures as a result of lack of knowledge? Yes. And that's what we work really hard on nowadays, is to simply share this with everybody so people will not have to learn from the same mistakes. There's a limit to how much you should densify bone and where you should use it. But to me, what's more impressive is that this happened in 2014. We are just starting 2017, and look at this. Completely sold out. Everybody wants to be part of this. Everybody knows what Versah is 3 years later. Is this a result of good marketing? No. Good marketing can only take you so far. This is a result of word of mouth. People have tried, they have used, and they keep using it. And by the way, I did work with Dr. Coelho and Salah in research, but I am a customer. Salah has even offered to send me like free drills whenever I want. Like, no, I want to buy it. Because if one day this doesn't deliver what I'm expecting, then I can complain, okay? So, having said all of that, we all know that bone is a very interesting tissue. Why is it so interesting? Because it has all these properties. That's what allows an athlete to jump this high and fall without breaking his bones. Bone is flexible when needed. It can widen in compression, can lengthen in tension. So it does have all these properties that we may not be paying too much attention to. And this is what densification is also reminding us of all of this, that there's a lot more than bone can do for us. We know that there's a need for bone for implants to be successful. We need a certain amount of bone for that to be possible. All our implant osteotomies have always been subtractive, and we have been extracting bone, and then we end up a little short, and then we have to add a little bit more. We got good at this, as Mike Picas showed. We can grow bone in a lot of clinical situations, but do we really need to graft as much bone as we have grafted? We also learn over the years that not every bone is the same. Okay, if you still think that, it's time to, rethink all of that. There's bone and bone. It's not just the volume, and it's the quality. Not every graft material that is out there will give you quality. It may give you bulk, it may give you volume, but it may not give you quality. If the quality of the product cannot be guaranteed, it's probably better to minimize the need for grafting. Does that make sense? I think it does. And this is one of the reasons why this is changing the way I practice implant dentistry. I used to drill my osteotomies and it's like, okay, fine. If there's bone missing, I'll grow bone. But sometimes that bone looked great, at the end. Sometimes it didn't. So why not minimize how much bone needs to be grafted? When you look at implants and what has happened to implants over the years, once again, a lot of creative designs were used. Some of them were successful, others were not. What really changed implant dentistry is when a design was accepted and was used widely, the development of root form implants. These ones, they do have high evidence of being able to be reproduced on a regular basis, can treat a variety of types of edentulosum, and have shown high long-term success. When I was in school in the 90s, if I could just summarize all the literature in implant dentistry, it's summarized right here. What happened to implant dentistry in the 90s? There was a big battle between two implant companies, this one and that one. If you read all the papers that were published between 2000, 2005, or 6, they all talk about beak, or bone-to-implant contact. That was what everybody was after. The more bone-to-implant contact, the better. So who won the battle? This one won the battle, because it showed that having a rough surface would create more bone-to-implant contact. What nobody proved yet, or has shown yet, is how much bone-to-implant contact is needed for an implant to be successful. It's almost like you want more, but you don't really know how much you need. So this allowed us to place implants in a lot of areas where we had very high failure rates, like Mish said before. Posterior maxilla, then all of a sudden implants were being successful there too. This type of implant here wasn't successful in posterior maxilla, and that's why it was discontinued. So this company won the battle, and it changed the industry. Changed the industry to what? All implants have to have a treated surface to be successful. But if you go back to Mish and everything that he said, the need for that rough surface to increase bone-to-implant contact was not anywhere in the mouth. There were specific areas. Oh, but it's too complicated to have two surfaces, one for the front, one from the back, so let's just, keep that. What is probably one of the consequences of that? Problems that we have nowadays. Yes, this has allowed us to do work like this, deliver results like this to our patients, and impress a lot of people when you show these pictures. But the problem is that none of this matters if 3, 4, 5 years later, this is what you see. I'm not saying that surface roughness is the only cause of periimplantitis, but we all agree that that's an aggravating factor. Well, once that bone starts to remodel and this rough surface becomes exposed, who can stop that? So, did this patient really need this rough surface here in the anterior mandible where he has D1 to D2 bone? Probably not. For those of us who have had a chance to look at cases that were treated 30, 40 years ago with machine surface implants, we know that, yes, there was some remodeling based on the connection of the implant, but periimplantitis doesn't seem to progress as fast around those implants. Something to think about, and I'm going to show you what we have been working on. Implant dentistry evolved significantly, but there is always one side of implant dentistry that was ignored. And this doesn't make any sense to me. We're all dentists. Dentistry is all about instrumentation, right? If you don't agree with me, try to prep a molar with a carbide burr and a low-speed handpiece. You know how that's going to look like? So we never cared about instrumentation in implant dentistry. We care about the implant, but not how we instrumented the osteotomy. So if we could just summarize it all, it's basically all the drills that we have ever used were simply adapted by the medical profession from drills that were used to cut other types of materials. If you look at the implant drills that you have in your regular implant kits, they're nothing different than any drill bit that you're going to find at Home Depot. They just cost like 100 times more. And the ones at Home Depot don't fit on your latch handpiece. So, but even at Home Depot, you see that there are different kinds of drills. Try to get a drill bit to cut wood, to cut metal, and tell me how it's going to work. It won't cut. And the same is true for a burr that is designed to cut metal, to try to cut wood. It will burn the wood. It's not going to be effective. So they are specific for their application. Our drills were never specific for that. They were just designed to cut bone, whether it was like D1 bone or D4 bone, all the same stuff. When you look at the design of a drill bit, there are specific functions that a drill bit has. The only cutting happens right here, and all the flutes that you have on a drill bit are only used to remove debris from the bottom of the hole. Because if too much debris accumulates at the bottom of the hole, what happens? It burns the tip because you can't cut any further. So that's the only function. So if you look at that from a different angle, let's look at this perspective here. If you think about it in a cross-section, a drill bit is like a fan that is blowing towards your face. Since everything is being extracted, what do you think happens with the cooling that you're adding to the drill bit? It hits the burr and it comes back. But if you reverse the fan, what would happen? Everything would change. The irrigation that touched the drill bit is shot immediately apically. And that's one of the things that you're going to see very clearly with the Versah drills. Drill the implant osteotomy, and after you're done, hold the drill and tell me if it's not cooler than it was before. So we know that we have always used irrigation to avoid what? Overheating a bone and killing bone. So with these drills, since they have this design, this is minimized or prevented. When you compare a regular drill with Versah, in this model here, and I'm sure that all of you have seen this, but I'm going to point it out in a different aspect. Here you have these two drills, regular implant drill and a Versah drill, working in reverse. By the way, you can only use this drill in reverse in something like this with a gel. What this drill is doing is simply extracting what needs to be extracted from here so that as a hole is created, while everything is being reinserted into the hole when you have the fan working in a different direction. That happening, what's the consequence of all of that? The consequence is that all the debris that would normally be removed is being reinserted. What is the effect of that? Well, it may be positive, it may be negative. It all depends on how much you do. What I think it's important to remember is that these drills, they cut in clockwise, but it also cut in counterclockwise. Let's not forget that. I don't need to densify all the time. How do you know how much you have densified? It's easy. You have a pilot drill and you drill that to 13 millimeters. You use the first Versah drill in reverse and you take it to 13 millimeters. You go to the second one and it doesn't want to go to 13. So what do? You push harder. Why? Because it doesn't want to progress. Why doesn't it want to progress? Because it has already filled up the whole bottom with bone. So by pressing more and not extracting anything, what you're doing is you're just creating heat. You might be killing the bone that is in the osteotomy. So when you feel that, I immediately switch the paddle to forward and I extract. Because some bone that may be also already almost like a G2 type of bone can only be densified at the very last drills. So you don't use the whole sequence in reverse. You use the first ones in forward and the last ones in reverse. So you play with that. If it ever happens that you cannot progress any more apical with your drilling, extract and then densify at the end. That's how you overcome all of that. The consequence of that is what Dr. Quaice called the halo of osseodensification. To me, this can go a little bit further. Since I'm getting all these marrow spaces obliterated with bone, what I think is being created here is an implant laminate dura, just like sockets have. Imagine, we don't need to change the density of all the bone in posterior maxilla because it has poor quality. The only bone that matters is the bone that surrounds the implant. If you look at teeth, it's exactly the same thing. It doesn't mean that patients lose more maxillary molars because there's less bone density there. What is around all these teeth? Lamina dura, bone that is adapted to remodeling. But if you don't recreate this, nature won't recreate it for you. So what is being created here is an implant lamina dura. Scientific evidence, Dr. Coelho has already showed a lot of this work, but I'm going to show you what I think is extremely significant to the everyday clinician like myself. Let's look at study number 1. This is a very early study. We didn't understand things very well, but we used the ship model once again. And in this model, basically what we were doing is just drilling osteotomies and checking for insertion torque. If you pay attention to this image here, what do you think that happened to this implant here? We recorded 100 Newton centimeters of insertion torque, but there was probably a lot more than that because it completely stripped the implant at 100 Newton centimeters. So we were testing this to see what happened, but obviously we weren't so hopeful that we would have a good clinical outcome because the insertion torque here was too high. So we were expecting, yes, we get better insertion torque, but the bone is going to die because there's just too much insertion torque. Then when you look at it histologically, that's not what we saw. Actually, we saw exactly the opposite of it. So what was happening here? Why were we inserting implants with so much insertion torque and not killing the bone? The truth is that that insertion torque was not coming from under-preparation of bone like we always did. So when you under-prep bone too much and you put a fat implant in a small hole, what happens is there's a constant pressure against that leave-in tissue. It creates a tourniquet. It creates ischemia. It prevents healing. It kills the tissue. We were getting high insertion torque simply by recreating this lamina dura. There was a solid wall of bone where this implant was placed against. It was filling all the spaces. And that's why it wasn't detrimental. So there was no under-preparation happening here where we get this type of result. And that's why the regular drilling sequence resulted in pretty much 99% of spinner implants in very low bone density. The hip has very immature bone. It's like a D4 to D5. It's a great model to study that. So if you compare like high power, low power, you can see the difference. Has the whole hip quality of bone changed? No. But in immediate contact with the implant, it has changed. And that's what matters. That's what our implants need. Let's look at study number 2, which to me is groundbreaking. If you look at study number 2, and this, by the way, we asked to do this study just out of our own curiosity, okay? Dr. Coelho and I would sit down and we talk about things all the time, and we are trying to find answers for paradigms that were created in the past and may not have been completely explained. So one day we were talking about this whole shift that happened in the 90s, that all implants having rough surface and everything else. So like, wow, if you can create this lamina dura with densification, what would happen if we try to use machine implants again? So this is the study. We're basically comparing insertion torque of machine implants and acid etch implants. So this had the same results as before, but as you can see here in terms of insertion torque, with densification, we managed to overcome the deficiency that it has. Why did smooth implants have a less insertion torque in poor bone density? Because they're basically just slippery. They weren't rough. Now we have bone that is denser in that area, so they can have the same level of insertion torque. Then what happened as a result of healing? We had the same results, same comparison. If you compare like machine implants and acid etch, same pattern. So the question is, do we really need rough implants in 2017 with the technology that we have right now? Something for us to think about. So you look at the histology at 6 weeks, same results, even more mature bone. If you just compare like acid etch and machine implants, you can see. So having said that, I'm not saying that this might be the only answer, the only solution for the problem that we are seeing. But if I can think of a fast solution for this problem, this could be it. Remember that all implants are born machined. Surface treatment happens after. Okay? So all implants that you buy in any company, they were born machined. That's how they are cut. If they're just sterilized right away, they're good to go. Implant companies can do that tomorrow if they want to. And I do know that 2 or 3 are already looking into that based on what they have learned from our studies. So what we might see as a result of this is a new change in implant dentistry, where we may see this type of implant go away. Because now we can afford to do that without losing the predictability of osseointegration by simply working on instrumentation. So maybe when we found a solution for this 20 years ago, we were looking at the wrong side of the game. We should have looked at this side, changing bone, so that our implants could still be successful. We didn't have the technology, but now we can afford to do this. Okay? I'm not saying that we're going to place like this type of Brandmark implants again. With the designs that we have, with the improved macrostructure and the design of the threads themselves, we can have a very successful implant that might be machined. So why is osseodensification a paradigm shift in implant dentistry? Wait and you'll see. Here's what I have learned the hard way, and I want to share with all of you. The notion of compression and densification. Compression is what we've always done in implant dentistry. If you look at the final drill size for any implant that you place, it's always significantly smaller than the size of the implant. That's how we achieve primary stability. Usually we under-prep by about 0.6 to 0.8 millimeters, which is significant. Some bone may afford that because it's soft, so it may accommodate that. Sometimes a bone may not. And that's why using like a drill tap and other devices to minimize that was always recommended. So if you have wood, wood can give. And that's why you have self-tapping screws for wood. What is the consequence of that in living tissue? Too much compression, as I said before, localized ischemia kills tissue. So how much are you compressing? Can you tell? Well, I'm inserting the implant is halfway down, I'm like already at 16 eurocentimeters. Should I keep going? No. Because if you simply keep going, you may be creating too much compression. So when we densify tissues nowadays, or densify bone for implant dentistry, I'm not looking at 80 eurocentimeters of insertion torque. I'm not looking for that. I'm looking for 35 to 40. So in some situations, I actually over-prep crestally while densifying so that I have this optimal number. I worried about excessive densification. And this is something that we should keep in mind. You can play with that with the system that you have. Just don't get too greedy and start using it where you don't need it, because you may have negative effects as a result of that. What we look for is this. Metal cannot be compressed. If you try to use a metal screw, the metal screw is always exactly the same size of the hole. So since metal doesn't expand, we have a hole that is exactly the same size of the screw. That's what we should be, this should be our goal with densification. We should create osteotomies that are dense, yes. But that doesn't mean that you should still under-prep the osteotomy. That's mistake number one with densification. Change the way you think. Change what you've learned. You've always learned to drill a small hole to place a big screw. When you densify bone to D1, D2 level, if you still under-prep the osteotomy, you will create pressure, compression of bone, and eventually may cause necrosis. So careful with that. It's something that you have to learn as you do. This is what we're looking for. Optimal insertion torque without causing excessive compression so that we can treat our patients sooner. We can rehabilitate them sooner. We could place that implant in optimal contact. We may not be necessarily looking for a 4-month healing period for a lot of cases. We may be able to load them immediately. We may be able to even put final restorations on these implants a lot sooner. So this is something that is very special about the whole protocol and something that needs to be respected. Why do I use that? Because of this. It gives me precision. Clinicians like Mike Picos, for example, and so many others in the room here, master clinician Paul Rosen, for example, 20,000 implants under his belt, they don't need this much help anymore. I can't wait 20 years to have the same experience that they have. I need to treat my patients today. So this is a tool that allows me to do what I want to do even if I don't have that experience, because it gives me precision of cutting that I never had before. So regular drills, since they only cut at the tip and bone doesn't have uniform density, we all know that this drill will shatter as density changes. So it's almost like the bone density will guide where the burr is going to go and not where you definitely want this implant to be placed. That is a big difference. So, and that is a main problem. With this drill and the haptic feedback that it gives you, it allows you to do what? To understand where the different density is and where it may guide you and follow either the right direction or change it as needed. So I think that this is a very useful tool for something that we do a lot nowadays, which is immediate implant placement. So because this burr talks back at you both in forward and reverse, it allows you to have a precision that I never had before. And trust me, I've used all implant systems out there, drew all the sequences, and I think that this is even more important for the less experienced clinician. I'm an educator, I work in a school. I can't expect my residents to have the same experience that I have and to be able to deliver the same results on a regular basis. I know how often they ask for this burrs in order to have more confidence in what they're doing. So this makes your lives easier and more reproducible. This is the situation where we always have issues with immediate implant placement. Anyone can place an implant on a heel site, on a fat ridge, but go place an implant in a situation like this and place it exactly where it needs to go. Oh, you can always follow like one apex or the other apex and end up with a tilted implant and then let the restoring dentist deal with it later, right? You know how much that hurts your referrals. It's different when you can place an osteotomy exactly where it needs to be placed. So here you're not a victim anymore of bone density. You are doing exactly what you meant to do, and you're delivering the implant in the most optimal position. Where should we follow? Should we follow the palatal wall? Should we follow the buccal wall? What's easier here? You don't have to think about that. If the ideal location for these implants is centered within the socket, you can place that even if there's a septum in that place. That in forward mode. Towards the end, you may use densification to help fill in the voids between the implant and the osseous and the socket walls. Yes, you can. But usually if I'm doing immediate implant placement, I'm always using this in forward mode, and I'm using it for the precision that it gives me. So should we always place the implant with Versah drills? I have been. It's one of those things that once you try, there's no turning back, because it makes my life easier. My work can be reproduced on a more regular basis. Do we treat the gap between the implant and the bony walls? Yes, of course. We worry not only about how much osseointegration we're going to have in that implant, but also aesthetics. So we treat our patients this way with Versah. Like I said, sometimes you have to deal with a situation like this. So what do I follow to drill this osteotomy? Should I follow that socket, this apical here? No, probably not. That's exactly where I want this implant to be placed, and that's what I'm going to do. Am I going to fill the void with a better material of choice? Of course I will. I tend to use allografts only as my grafts materials. And in a situation like this, because I still have a buccal plate and a palatal wall, I think of like, what am I missing here? Am I missing like dense cortical bone? No, I'm missing trabecular bone. So my graft of choice in a situation like this is always cancellous bone only, 100%. Why? Because I worry about the quality of the tissue around it and not just about the contours of the soft tissue for aesthetics that a lot of patients may not even see. I'm not saying the aesthetics is not important. I'm just saying that you have to be conscientious of what is more important and where. I see sometimes people filling in voids around second molars, lower molars, with biomaterials that don't turn over. What's the point of that? Are you worried about aesthetics of that second molar? That material that does not turn over may come back and affect that implant down the road. So we also have the same precision. We can apply the same precision in situations like this, flapless implant placement. Situations like this, I don't even use a punch. I just go through the soft tissue with it. It allows me to place that implant exactly where that implant needs to be placed. So if you still like to follow APSIS to drill your implant osteotomies, what happens when the tooth is not in an optimal position? What do you do now? Are you going to just abort surgery? No, you don't have to. But try to do this with a regular implant drill. Try to drill against a slope, against a cortical wall, and tell me what will happen. It's going to shatter. It's always going to find that apex once again. This is using the drill in forward mode, creating my osteotomy exactly where it needs to be created. Situations like this, I don't use the pilot. I go straight to the very first drill because it's side cutting and end cutting. The pilot is only end cutting. And with that, I can place that implant exactly where it should be placed. Another effect that you may have here is if you use then counterclockwise or densification mode at the very end. Look what a bank of bone I have down here that can be easily transferred to where I'm missing, which is the socket of the previous tooth. So you see a gradual fill of that space with the bone that is coming from where you're drilling your osteotomy. So there's so many things that you can do. You just have to think about all the options and all the possibilities that you have. So here's the implant finally placed and restored and successful, or not restored yet. Another very useful application of densification is one step further of immediate implant placement. Is when you have those challenging aesthetic cases that to me are always best treated with simultaneous implant placement and provisional. But then you're taking like a big risk. I'm extracting the tooth, placing the implant, and putting a restoration on top of it right away. Is this immediate loading? No. These temporaries are not in occlusion. But passive occlusion will always happen. The patient may bite a piece of bread one day and get some load on it. So getting ideal insertion torque in situations like that is key. Not every implant system will offer that. And what I think is interesting about densification is since it's universal, you can use for any system, you can choose how much densification is needed based on implant design. This is an implant that has horrible insertion torque, as you all know. It took me like years to try to use this implant for immediate placement and loading. I only started using it after I learned about densification. I never took the chance before. I placed a lot of immediate implants. They were always spinners. I'm not going to put a temporary over a spinner. So I densified. Now I have optimal insertion torque. Now I can go ahead and temporize the case. So implant being placed, provisional being made with the patient's existing crown, patient sent home, comes back 4 months later, is ready to be rehabilitated. So this is something that you can try on a regular basis with a high degree of success. If you want optimal aesthetics, I still don't think that there's a better way, reproducible way, preserving the existing tissues, supporting them with a provisional. Don't allow the soft tissues to heal around this round healing abutment and try to develop everything again with a temporary later. Just do everything from the beginning, preferably with an existing crown or the crown of the tooth that was extracted. With that, you continue to provide support to that soft tissue and you maintain aesthetics for the final restoration. And you can see like before and after, instead of losing aesthetics with immediate placement and temporization, the case turned out to be more aesthetic than it was before. What are some other applications of osseodensification? This is one that has been discussed a lot, and a lot of people have adopted densification for this only application here. Cresto sinus elevation. Like Mike said before, I was never a very big fan of Cresto lifts. Why? Because after you get very comfortable with the lateral approach, it almost feels that it takes twice as long to do a Cresto than it is to do a lateral approach. Not only that, but I'm completely blind. I don't know if there's a perforation or not. Yes, I can ask the patient to blow the nose and close it to see if there's a bubble, but that's not enough. How many times have I filled that osteotomy with bone and pushed that bone up, and maybe there was a perforation and all that material ended up in that sinus so that I ended up with no lift? Many times it happened. This system brought me back to the Cresto sinus elevation because not only it's more gentle on the patient, we don't depend on the osteotomes to break the sinus floor, but it also helps me insert graft material into that socket, something that I always struggle with. You know exactly what I'm talking about. You have broken the floor of the sinus, you start to add material, and then you tap a little bit, and you do like 3 or 4 times, and you're going to do that by the 5th time. Your assistant comes over and says, like, oh, your next patient is ready. It's like, okay, that's enough. You just put the implant in. And you take an x-ray, there's like 1 millimeter of bone and 3 millimeters of the implant inside the sinus. So with that, you have options, as you all know. These are all the available methods for Cresto lift. But since we have this reinsertion of material apically, we have the capacity to do this with autografting. Yes, Dr. Quaice has done this hundreds of times. I haven't. So I always take things one step at a time. I cannot compare my experience with his. So I don't do autografting. I don't trust autografting 100%. But I do trust the drills to elevate the sinus membrane. How does it work? Well, why wouldn't this drill here cut the sinus membrane? It will cut the sinus membrane if you push against it. Anything will cut the sinus membrane. But how does the elevation happen? Remember this. I told you that if you use this in reverse, you have irrigation being shot at the drill and forced apically right away. It's a hydraulic lift of the membrane. So what is your goal as trying to do a Cresto lift with Versah? You do your osteotomy, and you can feel when you're at that cortex of the floor of the sinus. The minute I feel that I lost that resistance, I stop. That is my working length. That drill will never penetrate the sinus again. That's how I do it. So why can I be sure that I was safe and I did not perf the membrane at that point? Because there's always water apical to where the tip of the drill is. So the minute I broke that floor of the sinus, water immediately pushed it up. But I'm not going to be pushing my luck here and keep pushing with the burr against it when it's rotating at 1200 RPM in reverse. I'm going to record that as my working length, and I'm going to progress my osteotomy preparation until the desired size that I need, always with that working length. What do I do at that point when I finish preparing my osteotomy? I'm going to use then a biomaterial. That's how I do it. If there's no need for a biomaterial, if I had a 9 millimeters of ridge height and I'm placing a 10 millimeter implant, then I think that autografting is very predictable. More than 1 or 2 millimeters, I think it will really depend on sinus anatomy. And a lot of patients do have a very significant distance between the lateral wall of the sinus and the medial wall of the sinus. So if there's a big hole in there for that autograft to be filled, you can't expect it to be all around the implant. That being said, I tend to take a more conservative approach with autografting. But here are some examples of autografting being done by Dr. Quaice. I've tried to do this, never had exactly the same results. So if you are starting to do this, maybe you should take my approach at first. Learn, get experience, and maybe you can push the technique a little bit further. So this would be like an outstanding result with autografting only, but I tend to use that in very limited situations. So for example, this patient showed up one day, root fracture, tooth had to be extracted. I know that there's a proximity to the sinus. Combining extraction and Cresto sinus lift was never, I never liked that approach very much because I always worried about how I'm going to be able to seal that sinus if the socket is not, the implant is not sealing the socket completely. So here I take a conservative approach, extract the tooth, preserve the site, put the bone graft in the site, cover it up with a membrane, allow this to heal for a good 3 or 4 months. Patient comes back, and that's what the site looks like. What am I going to do at this point? What I'm going to do is I'm going to use the same approach that I showed you before, and I'm going to do a flapless implant placement because I have this much residual height. I don't know exactly where the sinus floor is. So to me, this is just a no-brainer, something very easy to do. Oh, maybe the graft hasn't healed completely. I don't worry about that because I can densify it if I feel that the density is not ideal for implant placement. So here my osteotomy preparation, finishing it up. Here's the implant placed, good to go. In and out, less than 10 minutes. What did I do? Place an implant, densify bone, and did a minor Cresto sinus lift, all with one tool. To me, that is significant. That is significant for anyone here because, yes, maybe you have other devices that you can use, but everything is like, oh, ask your assistant, go get the Cresto sinus lift kit. You don't need to do any of that. You flip the pedal to forward and reverse, and you have everything that you need. So the simplicity and the versatility of use is amazing. So here's the patient being sent home, 10, 15 minutes later, and it's good to go. And that's very comfortable with that, okay? How much did I get of autografting here? Only time will tell. That's a new implant that I placed. I don't have follow-up on it yet. But so far, healing very positively. Situations like this, will I do a Cresto lift? Well, in some situations, you might have to. And in some situations, you can also use the combination between Cresto sinus lift as well as expansion of any septum for immediate implant placement. So here I have what? Expanded that septum so that the implant is completely surrounded by bone. Grafted all the voids with cancellous bone, cover it up with a long-lasting barrier, suture it up. But what I like to see is that after the site has healed, what I worry about in a situation like this is what? Position of the Cresto bone. This approach has allowed me not only to have bone away from the implant where I added the biomaterial, but what's more important, in immediately contact with the implant. Again, another thing that you can do, flip the pedal, and you get it done. Here's my approach to Cresto sinus lift. I use 7 as my cutoff point. Less than 7, I always worried about placing an implant simultaneous with the Cresto lift. Stuff that I learned from Mission, I keep using. The truth is, you can push the envelope. You can push the envelope, yes. but the cost of a failure is tremendous. Not only money, but reputation, dealing with a patient after a complication. So I tend to have a very conservative approach. So if this works well with 7, I use 7. So here I have 7 millimeters. What's going to be my working length? I'm going to decide that as I'm drilling. I felt that I broke the sinus floor. I enlarged the osteotomy. And then what's next? Well, thinking about how the drill worked, it reminded me of one thing. Well, if this drill shoots everything apically, what would happen if now I used the drill to insert the bone? So this is a putty graft material that is nice and radiopaque that I had. I placed that in that osteotomy. But then I flipped the pedal to reverse, but I dropped the RPM to 50. Why 50? Because I want now this drill to work like a Lentulu drill. We all know what a Lentulu drill does. Spreads that material apically. If I go at 1200 RPM with this, I may pulverize that graft and insert it too forcefully into the sinus. That's not what I'm looking for. So I flipped this in reverse and filled it up. Went ahead and start adding. So very easy now. I don't have to be tapping, and very much faster than the regular approach. So comes in a syringe, filled it up, put it in reverse, took it all the way up. How far did my drill go? Only up to the sinus floor. Oh, but I want to put a 13 millimeter implant. Should I take the drill to 13? Absolutely not. Your working length will always be the sinus floor only. The graft material will continue to elevate the rest of it. So you continually place that, and you take your time, and this is what you end up with. From 7 to 15 with a very conservative and gentle approach on your patients. So this brought me back to Cresto sinus lift in situations like this. The minute I finished up the case, I took a picture of it, sent it to Salah. I said, Salah, I think we just found something new about this. So can this be done on a regular basis? Yeah. Case of one of my former residents, Dr. David Lipton. I told him, I showed him the case. He went ahead the next day and did exactly the same thing. So I like techniques that can be done, can be used by many, irrespective of experience. So many amazing things that you see in big conferences. Try to do them yourself, and you know exactly what's going to happen. I like things that everybody can do. So next day, he did exactly the same thing. Simple. All with the same tools that he's using to place the implant. The last thing that I'm going to show about other applications is something that you might have seen already, which is ridge expansion. With this approach, you can expect to place an implant that is 1 millimeter larger than the size of the ridge that you have. How does that work? Does it make any sense to do that? Like, well, for you to expand the ridge, you have to go at least to the size of that ridge with any instrument, whether it is an osteotome or a Versah drill, so that it can be expanded. Because otherwise, you're simply densifying. So how much you're going to expand will really depend on what size of implant you're going to place. Yes, you may be able to continue to expand, to 10 millimeters that ridge, but if you're only going to place a 4 millimeter wide implant in a 3 millimeter wide ridge, you really have to go to that far. No, you don't. So you have to make the decision based on the size of the implant that is indicated for the area where you're placing it. So results have shown, studies have shown that we can do this in a very predictable way. So that's one more tool that you have by just flipping that pedal. So once again, the versatility of use is amazing. If you look at this ridge here that is somewhat narrow for an implant to be placed, this ridge will only be able to be expanded if you have a Versah drill that will be to the size of this ridge or more so that the expansion will happen. So do I always expand the sides? No. It always depends on how much the ridge is willing to expand based on the size of the implant that I'm planning to place. Okay? So Here are some examples. It's a case by Dr. Quaice. You can have like a 4 millimeter wide ridge, develop it to a 7 millimeter wide ridge, so he can put a 3.7 millimeter implant. So, have I lost implants as a result of not understanding osseodensification? Yes, I have lost. How many? 4 or 5. But this expansion, this management of implant site preparation has allowed me to place dozens more than I would have placed based on the situation that I found. And that's what I'm going to show you now. So here's like an everyday situation where you open a posterior mandible, and all of a sudden you have a ridge that is not ideal for the size of implant that your restoring dentist asks you to place. He wants a wide platform so that he can restore a molar that looks like a molar. He doesn't want to restore something that will look like a tomato on a stick. He doesn't want a 3.5 there because that's all the bone that you found. So then what do you normally do? Oh, you graft, you come back and do some time later, or you go ahead and you drill the osteotomy, create a dehiscence, place the implant, and then do GBR, and you cross your fingers that the bone that you're adding there will work because that implant will integrate. And if the bone graft doesn't work, then you're creating an implant with periimplantitis from the day you're placing, right? So here, just enough for you to place your 6 millimeter wide implant without a problem. How much expansion happened here? The expansion only happened after I put the 6 millimeter wide rimmer to place this, this ridge, or to turn this ridge into something like that. And this is an area of D2 bone, as you all know. Let's look at this other case here, and this is a good learning case. I opened the area up to place implants, and it's like, well, I might be okay here, but I'm a little worried about there. I may not have enough bone to place an implant. Imagine drilling an oral osteotomy here. You know exactly what would happen. You would end up with a long dehiscence. So here I have finished my osteotomy preparation, and look what has happened. I haven't lost anything. I have expanded that site. But one thing that you have to learn about expansion is if you're expanding, you can further expand that expansion with the implant. So every time I expand to the size of the implant, no under preparation. I under prep the site, and what happened here? The buccal plate fractured because the implant itself will not continue to expand. This case, no problem. I did GBR around it. The implants are in at least. But if you plan to expand, always expand to the size of the implant. If you under prep it, when the implant goes in, the threads of the implant will fracture that buccal plate that you're trying to preserve. Okay? Case is finished up. But if you just look at instrumentation, this is what I had when I started. This is what I had when I ended. And I can see, I think anyone can see here very clearly how the expansion happened. Let me show you another example. Here you have a very narrow ridge, only about 2 millimeters at the top, widens a little bit more apically. That's the size that I need to place the 3.7 implants that this patient needs. Oh, but that buccal plate is super thin. What are you going to do with it? What we know how to do. Basically, you have the implant placed in, good 45 newton-centimeters of insertion torque, which is pretty ideal in a situation like that, and I'll GBR around it, and everything's going to be fine. But instead of being a two-step procedure in which I will graft first and then place the implant later, I do everything at the same time. So it gives me the capacity to place implants where I normally wouldn't have placed. In this case here, I expanded just enough to place these implants. They're covered by a solid cortical plate. It's my choice to either graft something like this or not. But this will also work well when you use older techniques that used to be a lot more forceful in our patients. Reed split, for example. Let's look at this case. When you open the area up and you find this. How can you place implants in a situation like this? If you expand just in these two areas, the bone is going to be too weak around this implant. So what am I going to do here is I'm going to do the normal Cresto cut, and I'm going to use the drills to work the same way as my osteotomes would have worked for expansion, but way less forceful, and now I'm able to control the force and do this exactly where it needs to be done. So here are the two implants placed. The implants do help secure the plates in place and keep them expanded. After that, regular GBR around it. Close it up, no pressure over the site, let it heal for 4 months. 4 months later, you re-enter the site, and this is what you have. So not only helps expansion, but it also helps during ridge split. Two things that are a little bit different. Keep that in mind. In conclusion, I think we have all seen that what we have here is very unique. It is based on sound research. It promotes densification, gives you precision, facilitates ridge expansion, and also helps with crestal sinus floor elevation. What we have seen so far, to me, is only the very tip of the iceberg. The more you all try, the more we're going to find out what other uses this system might have. To finish things up, I want to thank you all for your attention and for being here. But once again, thank you all to this man here for all that he has done for us. Otherwise, we wouldn't be here today. Thank you.